Good afternoon and welcome. On behalf of Allergy and Asthma Network, I'm Tanya Winders, and we'll get started in just one moment. Good afternoon and welcome. I'm Tanya Winders, the President and CEO of Allergy and Asthma Network, the host of this afternoon's webinar. Please note at this time that you can choose English and Spanish interpretation, and you should see in your control panel that there is an opportunity to choose the interpretation icon, the world icon, and choose either English or Spanish. If you choose English, then you will hear my voice. If you choose Spanish, you will hear the interpreter's voice, Sonia, who is with us today. So at this time, if you'll go ahead and select your choice. We do have several hundred people already on the line and over 600 registered for today's session. So we'll give everyone just a moment to choose their choice on these interpretation services, and then we will get formally started. Again, welcome to everyone. It's my pleasure to welcome you today to our United Let's Talk About It Patient-Centered Asthma Studies webinar. This is the second in a series of 6 webinars that are a part of a PCoRI engagement award to Allergy and Asthma Network to engage the Hispanic Latino community. Again, we will have the opportunity to speak, to have these services in both English and Spanish, and the handouts are also available in English and Spanish. So at this time, you can choose those interpretation services if you have not already done so. We have a full program today, so let's go ahead and dive in and get started. Again, on behalf of Allergy and Asthma Network and the team, our research team who leads this particular project, welcome and thank you for being here. Our time together today will give a brief COVID-19 update, and then we'll turn our focus to patient-centered outcomes research and a specific study called the PREPARE study that's led by Dr. Elliot Israel. Then we'll give a brief overview of what is patient-centered outcomes research and hear specific patient experiences with research and why those individuals chose to become patient advisors for this virtual dialogue series. The objectives of our time together today and throughout the period of the engagement award is to describe the impact that asthma have on the Hispanic and Latino community, as well as to discuss the role that you as patients can play in advancing the treatment of asthma. And then finally, to identify ways you can engage in research. So let's get started. First, everything that we have done over the past 18 to 24 months, and certainly in 2021, it has that backdrop or landscape of COVID-19 and how it's impacting the world. And we utilize the Johns Hopkins COVID-19 dashboard as our set of statistics and measurements on the impact of the virus on the United States, on specific states, as well as around the world. And so the COVID-19 dashboard as of today shows us that there are over 248 million cases across the globe with over 5 million deaths due to COVID-19. We do also see that the total vaccine doses administered now are in excess of 7 billion. And so we're making great headway when it comes to vaccination, but unfortunately we are seeing new cases and new mortality figures. Again, you can dive in deeper at the COVID-19 dashboard by Johns Hopkins to see what the status is in your state or in your country. And again, it's just a fantastic resource that really does help us to better understand what the impact of the virus is at this particular time. So now as we turn our focus to the patient-centered outcomes research that we're here to discuss today in the PREPARE study, it's my pleasure to welcome our guest speakers. And so we are going to hear first, as I said, from Dr. Elliot Israel, who is an asthma specialist and the principal investigator on the PREPARE study. Then next, we'll hear from Margie Lorenzi, who is an asthma patient and research patient advisor and partner to the United Let's Talk About It program, as well as we will hear from Courtney Client, who is with PCoRI, the Patient-Centered Outcomes Research Institute, as a senior program officer. And then we'll round out the balance of our time also hearing from Alex Colon-Moya, who is an asthma patient and research patient advisor and partner to the United Let's Talk About It program as well. So now I'll turn it over to Dr. Israel.
Hi, thank you very much. It's really a pleasure to talk to everyone. I was going to say see everyone, but unfortunately we can't see each other, but hopefully in the coming years we will be able to see each other. So I wanted to thank the organizers for inviting me. I'm really honored to be able to speak to you. And what I'm going to talk about is talk a little bit about asthma, and which is why all of you are here, and a little bit about how asthma impacts the Hispanic Latinx populations, and talk about why we're trying to do research in that area, and also talk a little bit about what research means in asthma and what patient participation in research means as well. And you're going to hear then from two of our patient advisors who've actually been involved in the research project that I'm going to describe, which has been looking at asthma in Hispanic Latinx patients and African American Black patients. Next slide, please. So first of all, one of the questions that was posed to me is, why am I interested in studying asthma in Hispanic Latinx populations? And the reason that we want to study asthma, we're going to get to this a little bit, is that there's really a very disproportionate effect of asthma on Hispanic Latinx populations. You're going to hear a little bit more about how there are more emergency room visits, there are more deaths in Hispanic Latinx populations compared to white populations. And so there's a big burden of asthma in Hispanic Latinx populations. And when people have tried to intervene, a lot of the interventions have not been that successful in terms of decreasing that burden for the population. So we're interested in trying to understand that better and understand what things might make a difference. So
Wonderful.
just to understand.
I was just going to say, Dr. Israel, thank you so much for that. We are going to engage with some polling questions. And so we have our first polling question up now, and I will launch that poll. The question is, if you have asthma, how many times have you gone to the emergency room or urgent care for your asthma? So I will launch the poll. You'll see that in both English and Spanish. Have you been 0 times, 1 time, 2 times, 3 times, 4 times, 5 or more times? We'll give everyone about 30 seconds to a minute to log in your response, and then we'll share those responses with the group. Again, it's so exciting to see several hundred patients on the line from all across the US, and really appreciate your interactive participation in today's webinar. We'll give it just another moment. Okay, looks like we've got a majority of people who have responded, so I'll end the poll and share the results. And as you can see here, actually 22% have not had any ER visits or urgent care visits for asthma, while 14% have had 1, 26% 2, 19% 3, 8% 4, and 11% experiencing 5 or more. Dr. Israel, we'll have you pick up from there.
Great. So almost 80% of the people in the audience have had to visit the emergency room for asthma. That's a lot of asthma burden. And then I think, Tanya, if you want to go on to the next polling question to understand some even more severe outcomes in asthma.
Absolutely. So that polling question, if you have asthma, how many times have you been hospitalized for asthma in the past year? So let's think about that last 12 months, 0, 1, 2, 3, 4, 5, or more. So we know that this COVID year, we have had reports nationally of fewer hospitalizations, but it'll be interesting to compare and contrast that with our audience today. So go ahead and log in your response. I see that about half of the audience has done so. Give it just another moment. We will, in the poll, share the results. Looks like about 35% of our audience today had 0 hospitalizations this last year, 18% 1, 22% 2, 14% 3, and then 11% 4 or more.
Yeah, so that's 65%, 2/3, 2 out of every 3 people who are responding today have been to the hospital with asthma. That's an extraordinarily high rate. And I think that gets to, again, some of the things we're going to talk about. And so now we're going to ask you some questions about what you think the burden is in Hispanic Latinx patients compared to Caucasians or white patients.
Right. Thank you so much, Dr. Israel. So we'll go ahead and launch this third poll question that says, asthma happens in Hispanic Latinx at what rate compared to Caucasians? The same, 35% higher, 50% higher, 100% higher. So we'll give everyone just a moment again to log in their response. Let me share the results now. So it looks like 14% say the same, 51% say 35% higher, 29% say 50% higher, and 7% say 100% higher. Dr. Israel, what are your thoughts?
I'm going to talk about this after the end of the poll. So I'm going to, because I don't want to influence people. So because there are 2 more questions, I believe.
Okay, so let's go ahead and launch the 4th poll question. So this one is a little longer, but says, how many times more likely are you to go to the ER? Are Hispanics or Latinx likely to go to the ER or hospitalized for asthma than Caucasians? So as the Latinx community and population, what is the hospitalization rate compared to Caucasians? The same, 2 times, or 5 times? We'll give it just a moment. And we'll end the poll and share the results. Looks like 20% say the same, 53% 2 times more likely, and 27% 5 times more likely. All right, I think we have one additional polling question here. So I'll launch that poll. The death rate of Puerto Ricans with asthma compared to Caucasians. Is it no difference that both are the same, 25% higher, 50% higher, or 75 to 200% higher when looking at the Puerto Rican population living with asthma compared to Caucasians? We'll give it just a moment. Looks like most of our participants have logged a response now. In the poll and share those results. 12% say no difference, 46% say 25% higher, 28% say 50% higher, and then 14% say 75 to 200% higher.
Okay. So if we can move on to the next slide. So here's some of the answers to some of these questions. So asthma occurs about twice as often in Hispanic Latinx patients, so 100% higher than in white patients, and about 1/3 higher in African American blacks. Hispanic Latinos and African American Blacks have double the rates of asthma-related emergency room visits and hospitalizations as Caucasians, and they get rehospitalized. So they get discharged and they get rehospitalized about 50% more than whites do. And only 14% of you thought that Puerto Ricans had a 75 to 200% higher death rate, but in different studies, the rates of death from asthma in Puerto Ricans is two to three times higher, 75 to 200% higher than it is in whites. And the problem is, as I mentioned, it's been difficult to improve these discrepancies. So people are dying at 2 to 3 times the higher rate. They're getting hospitalized at twice the higher rate, and they have asthma twice as much. And when I talk about the rates, that's adjusted for the fact that there might be more asthma in the Puerto Rican or Hispanic population. So let me ask you, why do we need medical research? And the answer is because we need to understand the particular concern about human health, such as what can be done to minimize asthma deaths in Hispanic Latinx patients. And we need to develop a scientific plan. And how do we develop a scientific plan? Well, we need to understand what the problem is. So we need to collect data and information. And we need to analyze it, figure out what the data mean. So yes, you get a lot of statistics. How do you make those statistics come alive? What do they really mean? And then if you figure out what you think might be the problem, you need to figure out how you're going to inform people about what the solutions might be, what you found, and how you're going to inform people about the solutions. So you need to figure out how to distribute these findings to those who are impacted, to the patients, the communities, the healthcare providers, the healthcare policymakers, the people who say whether you're going to pay for a drug or whether you're going to pay information, and payers and insurers, if you really want to make a change. Next slide, please. So, as I talk to you about research, I know there's a lot of different feelings about being in research and being researchers. So Sonia's going to ask you a question about that.
Yes, and we want your honest feedback and opinion here. How much do you trust researchers? A lot, mucho, a little, un poco, not very much, or not at all? So go ahead and log in your reply. How much do you trust researchers? Again, no judgment zone. We want your honest feedback. We know that there is a history in some ways of reason not to trust all scientists or all researchers. And we acknowledge that at Allergy and Asthma Network. We have done a lot of programming in this area. And so certainly we want you to be forthcoming with your own perspective. We'll give it just a moment. We're seeing lower participation rates here. So want to give everybody ample opportunity to log in their response to this poll question. Dr. Israel, were you going to say something while we're waiting on replies?
No, I was seeing intermittent results, and so I thought that those were the finals. So we'll wait.
Yes, yeah. We're still gathering responses. Interestingly, here we have a much lower response rate than our previous questions, but I will go ahead and share since it's been a few moments. 55%.
Yeah, some people are saying in the chat that they can't choose, that there's something wrong with the.
Okay.
I saw some people come across and say we cannot choose. Okay. Not letting me choose. Something's wrong.
Okay, it was a single choice, so perhaps that could be the reason.
Yeah, they're saying I cannot poll, I cannot answer, or something's wrong with the poll question.
Okay,
no,
one of our co-organizers has their hand raised. Mary, were you going to say something?
Yeah, it was flashing on and off. That I think it was stopping the. Remember, that's why I told you I thought I saw something in the middle. So maybe.
Okay. All right. Well, we will keep moving on. I don't know what happened with that particular poll question, but we'll
so I can comment at least a little. So I'm pleased to see that a lot of you, that most of you didn't say that you don't trust them at all. So I think that's hopefully we're making some progress. And I hope that after we speak today, that you'll have at least a better understanding of what the researchers do and how we go about it. And so I wanted to introduce you a little bit to what we do when we do clinical research and what we mean by clinical research. is research that involves people. And there are two types of major, big, broad categories of types of research you can do. You can do observational research, and that comes from the word observe or to see. And in observational research, nothing is changed. The researchers look to see the effect of something that people have in common, such as there have been studies looking at, okay, let me look at people who take vitamin E and see if there's an effect on heart disease, right? So all you do is you maybe ask people what they're doing or what they did. You don't do anything with the people other than asking them to answer the questions, or maybe getting some blood or something else. Then there are other types of research, experimental randomized controlled trials, where you actually do an intervention. You assign people to one or more groups, and when you do a randomized trial, you assign those groups by chance. So you say to somebody, you say, okay, you're willing to be in the study, I'm going to roll the dice, as it were, and I'm going to, depending on what if the dice comes up even, you get this treatment. If the dice comes up odd, you get this treatment. I'm using that a little simplistically, but what it means is that people get assigned by chance. One group gets the intervention, and so for instance, if you're studying vitamin E, maybe one group will get the vitamin E pill that has real vitamin E in it, and the other group will get what we call a placebo. It looks like the vitamin E, but it doesn't have vitamin E in it. Next slide, please. So which type of research is better? And why do we do experimental research, which is a lot harder? So the problem with observational research is that they have biases that can give you the wrong answers. Next slide, please. So I'm going to give you an example of vitamin E. So there were many, many studies that came out that looked at people who were taking vitamin E. And they said, oh, you know, when we look at people and we look at hospital rates and look at what happens, we see that people who take vitamin E, who tell us they take vitamin E, have lower rates of heart disease. But the problem is that it may be that people who take vitamin E choose to take vitamin E because they're more concerned about their health. Or maybe they have more money and they have money to buy vitamin E. And maybe because they have more money, they have better access to health care. And maybe that's why they have lower rates of heart disease. So there might be a lot of different things that are going on. Or maybe people who take vitamin E also take a lot of other vitamins because they like to take vitamins. And maybe it's one of those other vitamins that really makes the heart disease go down. Next slide, please. So people said, hey, it looks like vitamin E protects against heart disease. Let's do a real experimental study. Let's assign and randomize people to vitamin E. So they did a study where they assigned patients to vitamin E or a fake pill by the roll of the dice or the flip of the coin. And when they did that, what they found was vitamin E doesn't help at all. There's no benefit of vitamin D on heart disease. So if you take people and you take all the differences out and just do things where you randomly assign them to one treatment or the other, that doesn't turn out to be the case. And so that's why it's really important to do experimental research. And that's why we're doing experimental asthma research, because we want to find out the right answers, not the answers that really might be associated with something else. So if we think about research, I'm sorry, can we stay back on the last slide? There are different ways to help asthma research. You can be in a study or enroll in a study, and I think that's a really wonderful way to both help your own asthma and to help other people with asthma. And as you're going to hear later, you can become a patient partner if you have asthma or care for someone with asthma, so that you can help advise researchers and become part of the team that helps conduct research. Next slide, please.
Great.
So,
and thank you, Dr. Israel. Real quickly, we do have a couple of questions that I want to get to because they're very important. So one, why do you believe that the rate of asthma is higher in the Puerto Rican community specifically? Or do we know?
Well, I don't think we know for sure. Some of this might be environmental, related to the fact that maybe there's different exposures in different environments. and that maybe the environments that people in Puerto Rico are living in or people on the mainland of the United States are living in might be different in causing them asthma. Sometimes we think maybe there's a genetic cause. Sometimes maybe there's a difference in the way the genes are organized that cause people to be maybe more allergic, which might lead to asthma. That's part of what the research is about.
And then another important question, explain what a placebo is.
So a placebo is and I said this, and I'll say it again. A placebo is a inactive form of something. So for instance, when we talked about the vitamin E, we gave people, or that in that study, they gave people real vitamin E, and they gave people a placebo, which looked like the vitamin E, but didn't have any vitamin E in it. And the reason you do that is because sometimes what can affect the outcome of the study is your belief of what can happen, right? There's a lot of mind over matter. And so the way we think about things and the way we believe things will happen sometimes influences what happens. And so when you do one of these studies, you'd like to try to give people a placebo if you can, so that you can eliminate that part of the problem.
Great. Thank you for explaining that. Now, our next polling question, I'm going to go ahead and launch now. Would you be willing to be a research subject in an asthma study? Based on what you know, what you've heard thus far, would you be willing to be involved as a research subject in an asthma study? Yes, no, or not sure, or depends on my doctor if he or she thought it was a good idea, or depends on my family if they thought it was a good idea or not to participate. So we'll give everyone just a moment to respond here. Looks like our response rate's better on this one. So we'll.
It's flashing up again. I'm worried it's freezing.
No, we're okay. We're okay.
Okay, good.
Yeah. Don't worry. I'm the controller of the polls here. All right, great. We've got a pretty good response rate, so I'll go ahead and share that now. So 66% say yes, that is excellent, and so much higher than what we see in a general population. 4% say no, they're not quite ready to make that consideration. 11% not sure, and then 18% depend on if the doctor and or the family thought it was a good idea.
That's very helpful. So let's go on to so having given you that background about why we do interventional studies or experimental studies, I want to talk about a study that we've been privileged to be organized and be part of. And it's called the Person-Empowered Asthma RElief Study. And we kind of give that a short name. We call it the PREPARE study. You can see the letters that have been capitalized, and so we call it PREPARE. Next slide, please. And so background. So many of you in the audience have asthma, and many of you use an inhaled corticosteroid, Flovent, or one of the other budesonide, or one of the other inhaled corticosteroids, or you use something like Advair, which has an inhaled corticosteroid in it, or Symbicort, which has an inhaled corticosteroid, or one of the others. What we know is that those things are very effective in asthma, but in almost all the cases, they're prescribed to take twice a day. And we know that people, when they're feeling good, don't generally like to take their medicines twice a day. And so we know that adherence, or sticking to that plan of taking those medications twice a day, is generally poor. We know also that when we do studies and we empower patients, we give them the ability to, or instructions on how to do things, and we tell them to use their inhaled corticosteroid each time they use their reliever medication, right? So the inhaled corticosteroids are called controller medications. The albuterol is called a reliever medication, the one you take when you feel bad, and you take a few puffs and in a few minutes you feel better. We know if we have them take their controller inhaled corticosteroid, when they take their albuterol, when we call that PARTIX, patient-activated reliever-triggered inhaled corticosteroid, we know that that reduces asthma attacks by almost 50%. as compared to the daily use of inhaled corticosteroids. Why do we think that happens? We think that when a patient uses their albuterol or reliever medication for an asthma attack, we think they're opening up their lungs. And when we do that and they take the inhaled corticosteroid, the controller, at the same time, we think that that decreases the inflammation and the irritation in the lungs, so allows the lungs to heal up. So using the two together, actually, when things are beginning to act up, we think actually makes a difference, and that's why we see a better outcome. Next slide, please. So the question we asked, if we use Pardix, if we use this patient-activated, reliever-triggered inhaled corticosteroid in a real-life study in Hispanic Latinx patients and African-American patients, will they use this? Will this be something that you find you really think you want to do and stick with it? And will that improve outcomes? Will that make a difference? And will it make a difference in ways that are important to you, the patients, important to your doctors, and important for people who pay for all the medications? Because as I talked about in the beginning, the only way to make real change is you've got to get everybody together and agree that that's what's happening. Next slide. So we spoke with our patient partners, we spoke with our payers, we spoke with the doctors who treat asthma patients, and what we kept on hearing from everybody is one of the big things that really impacts people with asthma is exacerbations or asthma attacks. And so we said we'll look at asthma attacks if we want to ask this question. And we defined or explained that an asthma attack would be something with asthma where you had increased symptoms and you needed to take steroids either by mouth or by shot or intravenously, or you got hospitalized. And patients told us that when that happens, they miss work, they miss school, they can't take care of their kids, they can't go to their classes, they can't go to their job, they get fired from their job, they lose their job, their boss complains that, you know what, every other month you're out for 5 days, 6 days, I can't keep you as an employee. And so this is really having a real live impact on people's lives. And so we asked, can a patient-empowered strategy, the Pardix, decrease the number of exacerbations per year? Because that's what people told us was important. Next slide. So we organized a study, and PCoRI, the Patient-Centered Outcome Research Institute, agreed to sponsor and pay for this study. We enrolled 19 sites with primary care doctors and asthma specialists. And we said that we would recruit 1,200 patients, 1,200 patients, 600 African-American blacks, and 600 Hispanic Latinos. We said we would do this in adults because we don't have permission to do this kind of variable Pardix strategy in kids yet. And we would do this in adults whose asthma isn't controlled, patients who still have a lot of symptoms, or patients who said that they had to have a prednisone burst in the past year. And because I told you that the best way we can really do good research is to do randomization, we said we would randomize these patients, 300 African-American blacks and 300 Hispanic Latinos, would be assigned to Pardix. 300 African-American blacks and 300 Hispanic Latinos would continue with usual care. Next slide. And we said we wanted to make this real life. So in a lot of studies, they have people come in every month or every 2 months. Well, you don't see your doctor every month or every 2 months. And so it's not so real to do a study where you have people come in all the time. And what happens then is that really happen in the real world? What if I don't see my doctor every month or every other month? Is this really going to work for me? So we said we would do a study where we taught you once how to do this Pardix strategy, and then we'd follow you for more than a year, for 15 months, and we'd send a survey once a month saying, what's happening? Did you have to go to the emergency room? Did you have to have a prednisone burst? How are you feeling? So we finished the study, the last patient finished this study in April of 2021. So that's about 5-6 months ago. And we gathered all up the data, and the analysis has begun to see if Pardix decreased the yearly number of exacerbations. Next slide. I think we skipped one. Go back one. So, and this study was interesting in that we organized this study to really collaborate with the patients, the providers, and the healthcare system. So typically, research is conducted by trained researchers. PCoRI is different. We include patient partners who work with us as a team. You're going to hear from them. Next slide. I think you just skipped one again. Go back. Okay. And why did we involve research, patient caregivers as advisors in research? We thought, and PCoRI thought as well, that they would bring important views from people who will be really the ones who are going to feel the results of this by the study. And they should include what the research questions should be and what the outcomes should be. We also wanted to connect with a lived experience together with the research question, so that this isn't just kind of some research, oh yeah, they have something and they're measuring blood tests, and how does that mean anything to me? We needed to be sure that the outcomes were going to be important. We wanted to keep the research staff grounded so that they really understood what was happening. And also, we felt that by having participation of patients and people who take care of patients with asthma, that if we had a positive outcome, if it turns out that this really helps, that we would have a group of people that would say, hey, I live this, and I helped design this, and I'm interested in making sure that this information gets out, and helping us to understand how to get that information out, how to educate the general public. Because sometimes what happens is you do a study, you have a really good outcome, but then you don't really know how to communicate it or how to get it out into the real world. And then what happens is it sits on some shelf there, even though it's something important that could happen. Next slide, please. So, oops, again, something's going wrong with that. If we go back, just skip the slide. Okay. So the PCoRI patient advisor population, we were studying Hispanic, Latino, and African American patients, and so we felt we needed to have advisors from those populations. We have 9 Hispanic, Latino patients or caregivers. 3 of them speak Spanish only, and 7, or that's their preferred language, and 7 African American Blacks. What we did is we had conference calls weekly at the beginning of the study, then at least once a month, and those continue now 5 years later. Each month we have one of these conference calls in English and one in Spanish, where we share the same information. And we've been lucky, we've been able to involve the patient partners in every aspect of our work. The study question, developing the wording, and the educational tool for the patients. So they helped us design the questionnaire that we sent out once a month. They helped us design the video that we showed patients when we gave them that one instruction on how to do Pardix. They helped design the wording of what we did in terms of the instructions that we gave them besides the video. And they helped us design what we talked about in terms of how we would engage patients in the different studies. And that's been really, really helpful. Next slide, please. And as a result of this, what we did is we first, and what we did and when we had the conferences with the patient partners, their input made a big difference to the study. We changed the wording of our instructions. We had a long survey. We thought we would have a long survey, and the patient partners said, oh no, you're not going to get people to answer a long set of questions. You need to keep it down, keep it down, keep it down. We shortened the monthly survey. We also decided, based on the patient partner input, to give patients a choice of how they were going to answer the monthly survey. Did you want it online? Did you want it by a phone interview? Or did you want to get your survey by mail? We also, based on the patient partners, said, you know, when you make these videos, you need to make sure that you've got people like me in those videos. And so that was an important piece as well. The patient partners advised us on how to pay patients and how much to pay patients for completing each survey. And they also suggested that maybe giving people an incentive and being on a little bit of a lottery would also be something that people would want to do. And the other piece was they wanted to make sure that getting into the survey was going to be as easy as possible. If you got something on your phone or something on the internet, you didn't want to go through 5 things and a password to get to your survey. They said 1 click. You got to make it, I click here and I'm in my survey. Next slide, please. So what's the impact of that? Well, 1,200 people is a lot of people. We were able to enroll 600 Hispanic Latinos and 600 African Americans. These are sometimes difficult populations to enroll. Although a lot of you said you would be interested in participating in research, as you know, there's still a lot of distrust about doing research. The amazing thing is we have had consistent 92% survey returns at 15 months. We only ended up actually losing 4%, less than 4% of the monthly surveys. So 96% of the monthly surveys got answered. That's an unbelievable rate of responses. That's an unbelievable amount of response. We had a very low dropout rate through the entire study. 17 patients out of 1,200 dropped out. So that's, again, a really wonderful thing. And the instructions, I think, were pretty clear, and people felt that they wanted to do this, because 84% of the patients that were assigned to using the Pardix said that they did it. They told us, I'm doing it. When we asked them on the monthly surveys, are you doing it? 84% said they were doing it. That, again, considering that the normal compliance or adherence with inhaled steroids is 25%, to get 84% compliance is really hitting the ball out of the ballpark.
Great.
So
Thank you, Dr. Israel. Yeah, let's go to our next polling question. We are a little short on time. Would you be willing to be a patient partner advisor for an asthma study based off of what you've heard here? Let's launch that and give everyone a moment to respond. Great. Sounds like that we've got pretty much everyone. Let's go ahead. At least half have respondents. We'll end the poll and share. 78% yes, 3% no, 9% not sure. Depends on whether my doctor thought it was a good idea, or depends on my family, about 10%. So we saw a little bit of change in that time frame. All right, let's go here. And next we are going to hear from one of those.
Yeah, so I'm just going to say thank you. So I hope you're able to understand again why you can make such a difference participating in research, and I'm really privileged. You're going to hear from Margie and from Alex, who really have helped us with this study.
Great, Margie, go ahead.
Hello, everyone. Thank you for having me. My name is Margie Lorenzi, and today I'd like to talk to you about both my personal experience and my experience as a patient's partner. I am the mother of a young adult who also suffers from asthma. I have been a patient's partner also in the PCoRI study for the last 5 years, bringing my own expertise from the perspective of a caregiver, of someone who suffers from asthma, clearly my son. And I'll tell you a little bit about why I decided to be involved and participate as a patient's partner. It provided me the unique opportunity not only to share my own knowledge and personal experience that I have gained through my own personal knowledge, working in communities of colors and Latino, but also share my knowledge of those who worked with myself and others in the community who do not have a platform to share their stories for themselves. It also gave me the opportunity to build confidence through effectively discussing topics openly within different groups, and then acting on negative outcomes using research as a foundation, as Dr. Elliott was talking to you guys about. It also gave me the opportunity to take part in spreading awareness and consciousness, necessarily to bring about change within medicine, health industries, including the necessary conversations surrounding race, language, access, oppression, and other ethical concerns, amplifying voices and working with those that are most vulnerable populations. And in all, I have grown professionally, picking up techniques, aspects of what research entails, as well as participating in valuable ways that have contributed to the research of asthma. That has been my personal experience. I encourage everyone to join in some type of way about encouraging others also in your communities and join as a patient's partner. Thank you.
Margie. Thank you for being here and for sharing and for participating, for raising that voice. As a patient, as a parent, caregiver, we really appreciate your perspective. Now we're going to turn it over to Courtney Clyott, who's the Senior Program Officer at PCoRI, on explaining what is PCoRI and how you can get involved in programming there. Courtney?
All right, so can you see me? Because I don't see myself. Just wanted to make sure. All right, hopefully everything looks good. So I'll just go ahead and get started. So good afternoon, and thank you for the introduction. And thank you to Mary and Dee Dee and Dr. Graham and those others who have worked on this project, including Linda and Tanya, who've made this possible this evening to share with you information about PCoRI and work that we've also funded. So first, I'll start by telling you about where I work, which is PCoRI, and how our work is different from other research funders. You heard some of that from Dr. Israel. And then I'll inform you about what types of projects PCoRI funds and how you can get involved. Next slide. So PCoRI is an independent, nonprofit, non-governmental organization authorized by Congress in 2010. PCoRI funds comparative clinical effectiveness research that engages patients and other stakeholders throughout the research process. It supports work that will improve the methods used to conduct research, as Dr. Israel shared, like having patient and stakeholder engagement. And these efforts that we support seek to answer real-world questions about what works best for whom and under what circumstances. Next slide. So for all the advances it produces, traditional healthcare research has not answered many questions that patients may face. So people really want to know what is the best option for them in their circumstances. Patients and their clinicians need to have information to make informed healthcare decisions. And so PCoRI seeks to support these efforts, focused on answering some of the questions and providing the information most useful to patients, clinicians, and other stakeholders. Next slide. So what's different about PCoRI? Well, PCoRI, or Patient-Centered Outcomes Research, focuses on research topics that are important to patients, questions that are important to patients, and outcomes that are most important to patients. It works closely with a range of healthcare stakeholders and requires that patients be engaged in the research from start to finish. So that's the creation of the research ideas, or even the materials, as Dr. Israel shared, about how to engage others in a research study. Next slide. PCoRI is a relatively new form of comparative effectiveness research. It, as I said already, considers patients' needs and preferences. It investigates what works for whom and under what circumstances, and it helps patients and other healthcare stakeholders to make informed decisions about health and healthcare options. Next slide. PCoRI funded projects place high priority on conditions that are affecting large numbers of people, such as asthma, conditions that place a heavy burden on individuals and society, such as asthma. And also we do fund projects that focus on rare diseases as well. Next slide. So with PCoRI, patients and stakeholders are involved in research from the beginning of the research process, as I shared earlier. So that's from the development of even research priorities to the dissemination of research findings. And patients are considered subjects, are not considered subjects. They're considered partners, not subjects in research. And so at PCoRI, we believe that better research can be done through engagement, and that engagement can help to influence how research can be more patient-centered, how you can establish trust and a sense of legitimacy with research findings, and then also how folks can be encouraged to have a more successful uptake of research results after that research has completed. Next slide. Well, there we go. We can stay here. So engagement is one of the key pillars upon which PCoRI operates, and it's integral to our work and the work of those that we support. And in PCoRI's funded projects, engagement is intentionally used as a tool to advance research and to ensure that stakeholder voices are heard in the assessing of the value of healthcare options. And the projects funded under our engagement award program, such as this project here, this webinar this evening is funded by our engagement award program. The projects have been funded not for research, but for the purpose of engaging others in research, helping to build research partnerships, helping to build and develop patient-centered outcomes research capacity. So our engagement award program helps PCoRI to meet its engagement priorities of developing communities skilled in PCoR and the research process, and also involving communities in the active dissemination of that research once it's concluded. Next slide. So this slide here is a great visual demonstration of what makes PCoR different. So patients are involved in the planning of the research, the conduct of the research, as well as the dissemination of the research. And at PCoRI, we also have what we call our merit review program. So that is the reviewing of proposals that folks have submitted to receive funding from PCoRI. And we have patients who are involved in that process as well. Next slide. So I'll give you a little bit more information about our research portfolio, highlighting some examples of asthma and how much we've funded under our asthma portfolio. So thus far, we've funded about 1,800 projects for more than $2.9 billion. We have projects in 49 of 50 states, and you can see here that North Dakota is still blank. This next slide shows our most studied conditions, which are mental health and cancer. Those are the top two. And then this next slide here describes some of the questions that those who are asthma patients may have, such as, for instance, as seen on this slide, a patient with asthma may be concerned about the side effects of their medication as prescribed by the doctor. And health providers may also recognize that there are a lot of patients that they continuously treat. Maybe they're seeing them show up in in emergency rooms. And so with that, they may be seeking strategies to be able to engage patients in ways that they can control their asthma, as Dr. Israel has with his project. And so PCoRI funded projects like the PREPARE study from Dr. Israel that he just told you about. This is a great example of how we engage with patients and how researchers continue to engage with patients and have a better understanding of what their needs are and what outcomes are important to them. Next slide. So PCoRI has invested $52 million in about 15 CER studies that are related to asthma to this day. As you can see, all of the studies related to asthma have focused on racial and ethnic minorities. And several of them have focused on various social economic statuses, including those who may be of low income and or those who may live in urban or rural settings. And 10 of these projects have focused on children. Next slide. So you may ask who we involve, how do we involve folks in our programs, as I just shared with you. Ways to get involved include our ambassadors program, which I'll tell you about in a little bit, our training that we've made available to folks. And then we also have our merit review panels. And our engagement awards are ways that folks can get engaged with PCoRI as either patient partners, or if you work at a community-based organization, you can also apply for an award. Next slide. So these are further opportunities to get involved. So our ambassador program, as I mentioned, is like a volunteer network of individuals who are dedicated to changing the culture of healthcare research. And our ambassadors are volunteers and not representatives of PCoRI, but they are like our boots on the ground, and they help to supplement our organizational efforts. If you're interested in becoming an ambassador, there is, I think I included a link at the end of the slides. But you can go onto the PCoRI website and fill out an interest form and complete a short online training. Next slide. And next, I want to share with you about training that PCoRI has made available on its website. It is an interactive training, video-based training, and is called the Research Fundamentals Learning Package. So this allows you to move at your own pace and get a sense or a better understanding about patient-centered outcomes research or CER. And I think I saw in the chat questions about the maybe links. And so I would encourage you to visit www.PCORI.org. Next slide. So the objectives of the Research Fundamentals Learning Package include increasing stakeholder understanding of PCoRI CER and basic research principles, also enabling team members to understand what their respective roles may be or their contributions may be in a research project. The training also allows team members to obtain skills and learn behaviors to work successfully in a multi-stakeholder team environment. We also have a resource that we've made available called Best Practices in Multi-Stakeholder Team Science, and that can be found on our website too. This slide here shows you other ways to get involved with PCoRI, and those examples include our advisory panels. And each year, each of these program areas have openings, and the application process, I believe it usually closes in the spring, but it is currently open. So you can visit our website using the link that's on this slide. You can learn more about our merit review program, our peer review program, and lastly, I also have a link for engagement tools and resources. So I am guessing that there may be a question about whether or not Research Fundamentals is in Spanish, and at the moment it has not yet been translated into Spanish. However, we do have some tools in our resources, tools and resources repository that may be of use, particularly one created by a group called El Futuro. And so those materials are in Spanish and in English. And you can also subscribe to the PCoRI newsletter with a link at the bottom of this slide. And I believe the next slide is the last slide, perhaps. So this is my contact information. And then also I wanted to let you know that PCoRI has a meeting that will take place in about 2 weeks, November 17th through the 19th. It is a virtual annual meeting. It is free of charge. You can visit our website to register. Thank you for your time.
Great. Thank you, Courtney. We do have a quick question for you about how is PCoRI an IRB, or how does it differ from an IRB?
PCoRI is not an IRB. PCoRI funds research. And so anyone who is seeking to have research funded will have to go through an IRB at their research institution. We do have some projects in our engagement award portfolio that have worked with IRBs to help IRBs to better understand what it is that we mean by engagement. And in some cases, some of the projects have focused on helping people to have a better understanding of what engagement is and how, under our engagement award program in particular, those awards are for building research knowledge and capacity, not necessarily to conduct research at all. But sometimes IRBs don't have that understanding because they're looking at a research institution providing funding and they're like, well, aren't you getting funding for research? And that's not the case at all. So the IRB basically is the institutional review board. So it's at the research institution, or it could be a separate institution that reviews protocols for research. And that is not PCoRI.
Thank you, Courtney. All right. Thank you so much for that presentation. Next, we are going to go to Alex. Alex, if you could please share your story with us.
Okay, hi everyone, my name is Alex. I have been a patient partner for around 5 years for the PCoRI study. So first I will talk a little bit about myself and my experience of being a patient partner. So I have been a asthma patient since I was born. So I have been with asthma my whole life completely. And I have passed through all the steps of life, being an asthma patient and everything. So I actually know what it's to be an asthma patient as well, as all of you do. So if you have any questions, you can ask me on the chat and I will gladly answer that for you. So as many you know, asthma causes a lot of limitations to patients. It affects us daily. We cannot perform certain activities while we have asthma. We would like to be more exercise, maybe. We would like to go outside, and definitely that's something that it's limiting, and it affects us daily. Now, I am from Puerto Rico, so over there we got something that's called the Sahara dust desert, and that affects definitely and increases more our health, or decreases more our health, and activates more our asthma over there. And that happens between summer, and right now it's been extended to October. So it's quite big of an issue. So there are a lot of factors that definitely influence in asthma in our lives, okay? So there are a lot of things that activate them. So yeah,
Great.
I have seen,
Thank you,
I'm reading
Alex.
one of the, I'm reading
Yeah, just keep going. We'll
Okay.
get those questions
Okay.
over to you at the appropriate time.
All right, perfect. So as an overall, I saw one question about that asthma has cure. Asthma doesn't have a cure, unfortunately. So it can only be treated. So by this is why it's very important to do a lot more research on asthma and get more knowledge of what causes asthma. How can we improve our own treatment? So being a patient partner, it's been an essential part of our life, of my life actually. And I really encourage all of you to become a patient partner and participate in all of the studies that you can do, because it's the way that our voice is being heard. It's the only way that we can do, we actually make a change in research and in patients' life. So it's been an amazing experience. What we do as a patient partner, we put our knowledge, our experience of life, and it's been added in every single step of the research study. And that's very important because it's actually changing the way that research is being done. It's not just the researchers doing and getting the information that they need. It's not just that. It's actually putting our voice, our experience, what we actually need as patients. How can we change, or how can research be changed to help us actually better and get better asthma treatments and treat our asthma and improve our quality of life. So that's like a look, like a good overall. If you have any questions, you can ask me. Overall, really encourage you to become an asthma patient. Yeah, you're welcome.
So much. Thank you for sharing your own experience and for volunteering as a patient advisor and partner. And so now we are going to go to some of your questions as we have just a few more moments together. We'll spend about 5 minutes answering some of these questions. The first question is going to go to Dr. Israel specifically, or actually, I'm sorry, the first question is to Courtney. Does PCoRI support research outside of the US?
Yes, however, the research has to have an impact. Sorry, I should have been a little bit better prepared. You can visit our website for this information and for the exact quote, but the gist of it is that the research has to have an impact on, or the results of the research would have to have an impact on the US healthcare system. So it would need to be something that could be replicable or generalizable to other communities within the US healthcare system.
Great, thank you for that clarification. Now our next question does go to Dr. Israel, and it is it plausible to think that a patient with asthma may be at higher risk for COVID or complications from COVID?
That's a great question. We've actually looked at this. We published an article because the PREPARE study allowed us to look at the risk of exacerbations or attacks from asthma while people were sheltering in place. And so what we found was that there was a 50%, half as many asthma attacks while people were sheltering in place from COVID. Whether that will continue is something we don't know. We actually now know that it looks like inhaled corticosteroids, the controller medications, might actually decrease the risk of getting COVID for people with asthma. However, if somebody with asthma gets COVID, they might be at greater risk for being more ill or more sick because the COVID could set their asthma off. The answer is less attacks, probably a little bit less risk of getting COVID, but maybe if you get COVID, you might be sicker.
Thank you, Dr. Israel. And what we do know is that controlled asthma is the key, right? So if you have uncontrolled asthma, then we also, the data and studies would show that you're at higher risk for complication from COVID versus if you have controlled asthma where you're not having symptoms more than 2 times a week or waking up using your albuterol more than 2 times a month, that sort of thing. So if you have well-controlled asthma, then the complication rate is less. Now, the next question is just in regard to just the genetic role in asthma, and is it genetic only or is it environment and genetic? Dr. Israel?
The answer is yes, that there's a genetic role, we think, and there is a strong environmental role as well. So you need to have in general, a predisposition or a genetic predisposition or a genetic likelihood that you could develop asthma. But a lot of people have that. And then if you have that, if you get into the wrong type of environment, it can set your asthma off. Now, some people have asthma from birth, and so there may be a genetic piece or an environmental piece. We know there are environmental exposures during pregnancy that increase the risk of the child having asthma. So it really is a dual thing, but you need to have some of the ability to develop asthma before these environmental things can actually kick in.
So we have time for one more question, and it is a clinical question, so I'll stay with you, Dr. Israel. What is the difference between biologics, inhalers, MPIs? What's the difference there?
So biologics are a good question. Biologics are a new category of drugs that we're using for very severe asthma. They involve antibodies against different types of chemicals that are produced in the body that we know cause asthma. And so they're a different class of drugs. They're injected. They're not things you can take by inhaling them or by, at least at this point, by inhaling them or by taking a pill. But instead they're injected, and they are antibodies that go in and kind of counteract certain chemicals that are involved in severe asthma.
Right. Thank you so much, Dr. Israel, and thank you to all of our panelists. It has been just a fascinating hour and 10 minutes to review this. Now, as we close, I want to thank you all for attending and also encourage you to join us next month on December 2nd. We'll keep the conversation going. We'll take your feedback from today and then help it to shape our program for next time. Also, please sign up to receive our free Allergy and Asthma Network research newsletter. It gives you opportunities to participate in more research projects outside of the United Let's Talk About It. You can also join our asthma registry and get involved with AAN to participate in patient focus groups, advisory boards, research studies, be an AAN patient advisor, and always at allergyasthmanetwork.org. We have a wealth of free asthma and COVID-19 education materials. We would love to see you involved in more in our activities around Allergy and Asthma Network, as well as our asthma studies. And you can always contact Mary Hart, our Director of Research, whose email is here, and or the team who reached out to you for today's series and webinar. Again, I want to thank you, and on behalf of the team at Allergy and Asthma Network, we hope you stay safe and well and have a wonderful rest of your day.